Okay, well, good morning, and thank you for all being here today and allowing me to speak. I'm going to talk about new and emerging treatments for juvenile myositis. So we've come to understand a number of immune targets and the activation of these in patients with myositis. These include things like B cells, T cells, the production of autoantibodies, the activation of macrophages, and other different pathways inside the immune cells. And because we're having a better understanding of the different pathways that are activated in patients with JM, then we can develop more mechanism-based treatments. And we can use an approach that's more precise, that might target each of these specific cells and be less sledgehammer in its approach. It might be more personalized as well, individualized to the pathways that you yourself may have activated in the child. Often these types of treatments are biologic therapies. They may be proteins or DNA or sugars or even cell treatments. And they have the potential for less side effects because they are more targeted, although I will say that there are no free rides. So we're going to talk today about a very few of these different treatments targeting these specific areas of the immune system. We'll start with rituximab, which Dr. Reed already touched on. Rituximab is targeting the B cell, where it binds to a molecule on the B cell and knocks out the B cells. So as Dr. Reed mentioned, there was a very large trial that she and Dr. Otis led. It was a multi-center trial, the largest we've ever had in myositis patients. 200 patients enrolled, the majority of whom had adult dermato and polymyositis, but about a quarter had JDM as well. And when patients were randomized in a blinded way to receive the rituximab therapy early at week 0-1 or later at week 8 and 9. And they received placebo treatment at the other time. And there was the thought that patients who received the rituximab early would respond earlier to the treatment. In fact, as Dr. Reed mentioned, most of the patients who had moderately active disease and were refractory to other treatments, almost all of them responded to this rituximab treatment. But we didn't see a difference in who responded early and late in the trial overall. But as Dr. Reed mentioned, there were some differences about who responded early, and one of them was that the JDM patients responded earlier. And as Dr. Reed also mentioned, then there were certain patients with certain myositis autoantibodies who also responded earlier. And actually, Dr. Reed was able to show that those patients with the myositis autoantibodies also had a greater change in a certain hormone in the immune system called type 1 interferon. And they reduced that more in the patients who responded earlier. And we could also see that people with more of this type 1 interferon also had more of it in their muscle and reduced it more as well in the patients who had muscle biopsies in the trial. We also had a few people who received this rituximab treatment who flared before the end of the trial. It was almost a year-long trial. And when they were retreated, they also re-responded to the treatment. So there were a number of indications, I should say. The response was also very good, not just in the muscle with improvement of strength, but also in the skin rashes. So there are a number of indications from this trial that this rituximab treatment is really helpful, and now we're using it more and more as a second-line treatment for JDM patients. So we have another treatment called Abbott, also known as Orencia, which binds molecules on T cells. And there are certain activation molecules that are expressed on lymphocytes and on muscle cells, and we know that these are increased in the muscle and peripheral blood of patients with adult myositis. And this abatacept then binds this molecule called CD8086, and then it blocks the activation of the B lymphocyte, so it won't activate the T cell. And then there have been some case reports of improvement, but as Dr. Reed said, we'd like to get better evidence. So there has been a small study conducted in adult patients, again, treatment-refractory patients with poly and dermatomyositis who failed other immunosuppressive treatment. And they were randomized to receive this abatacept either right away or at month 3. And those that received it right away then responded at month 3 compared to those who hadn't gotten it yet. So we know that clinically that it was doing something. And we could also see, based on Dr. Lundberg's studies, that there was a alteration in the regulatory T cells, the T cells that suppress activation of the immune system, that they were upregulated after the patients received this treatment. And like rituximab, the treatment was tolerated fairly well. Some of the patients had a few infections, but there were no serious adverse events. So based on this preliminary data then, a very large randomized controlled study is being conducted now, mainly in adult patients with dermato and polymyositis, but JDM patients who are adult age are also eligible to enroll in this study. And then there's also a small study going on at the George Washington University Myositis Center just for JDM patients. And these are patients who are at least 7 years of age who are not responding well to prednisone and one other treatment and have moderately active disease. So Dr. Curel is leading this effort. We have another pathway in the immune system called type 1 interferon. This is a pathway where we think that we can see from studies that Dr. Reed and Dr. Pachman and others have conducted that there's the production of these type 1 interferons both in the peripheral blood, in the muscle, and in the skin. And that certain cells called dendritic cells are secreting these both in the skin and the muscle, and this is contributing to the active disease. So there have been some investigators that have treated muscle cells in culture with these type 1 interferons, and they could see that the muscles shrink down or have atrophy, just like in the patients, and that this can be blocked if we block that interferon pathway. So there's promise of a certain class of drugs called JAK kinase inhibitors that actually block the signaling of this interferon through the cell, and then that would lead, then we hope, to the downregulation of this type 1 interferon production. In fact, there have been a few reports in the literature from adult patients who have been treated with these JAK kinase inhibitors. One is called Tofacitinib and one is called rituximab. And patients who received these treatments improved their skin activity, as you can see here from the pictures of before and after the treatment, that the rash has gotten markedly better. And they also improved in their interferon gene score and interferon activity in the blood when it was measured. Similarly, looking at the muscles in the cell culture, muscles treated with this rituximab, the JAK kinase inhibitor, then were able to reverse the shrinkage of the muscle cell. And also the blood vessels that Dr. Pachman often speaks of that are affected by the disease were also improved in their ability to grow in the cell culture after receiving this treatment. So we think this is a very promising treatment for JDM and adult dermatomyositis. And there's a small trial in progress for adult dermatomyositis with one of these JAK kinase inhibitors called Tofacitinib. And then Dr. Hannah Kim, sitting in the back of the room, is leading a small compassionate use study for patients with severe refractory disease who have moderately active disease and would also have other signs of active disease through a daily diary score, and they can receive this treatment on a compassionate use basis. And this study is available through the summer for patients in need of this treatment. To see if this will be helpful and what the side effects might be in JDM patients. So we have another area in need of treatment. Some of you know about this, called calcinosis. Calcinosis is the deposit of calcium under the skin and subcutaneous tissue in the muscle in up to 30% of our patients with JDM. It seems to occur in areas of inflammation and at pressure points. Seems to occur more when the disease is active for a long period of time. It can be very local, but it can get to be very extensive, and it can result in a lot of functional disability. And we've tried multiple treatments, but without much definite success. We're still honestly defining the pathways involved in calcinosis, but we think the inflammation has something to do with this, and that there are also some bone matrix proteins that get deposited as well, and that the calcium deposits grow over time and get more and more crystallized. They're not bone, but they get more harder over time, if you will. So we have a new treatment that's being tried for calcinosis, not just in dermatomyositis, but in other forms of calcinosis that can occur in other diseases, called sodium thiosulfate. We have a few thoughts of how this treatment might work. It's actually a drug treatment, that it might bind the calcium and then make it more liquid soluble, if you will, and not such a hard rock. It might inhibit the pro-inflammatory cytokines and other inflammation pathways, and it might alter the blood vessels themselves. So we have a treatment trial now. We've had a few reports anecdotally in the literature of improvement of patients with this treatment, receiving it either topically or IV. So Dr. Adam Schiffenbauer in our group at NIEHS is leading a trial of patients with JDM and adult dermatomyositis who have moderate to extensive calcinosis, involving at least 2 extremities or the core of the body. Patients could not have received this drug in the past, even topically, and they can have severe osteoporosis or bone thinning because this drug has the potential to thin the bones in and of itself. Patients need to qualify for the study and then come see us for 6 visits over more than a year's time, and one of those visits would be to receive the treatment IV 3 times a week for 10 weeks. During a stay with us at the NIH Clinical Center in Bethesda, Maryland. And of course, patients will undergo a lot of different testing to see how this medicine is working and also to see how safe it is. And if you know any patients who would be interested, you can have them contact Dr. Schiffenbauer. So today, then, we've learned that we're developing more targeted therapies that are focused on specific biologic mechanisms in the immune system, and we hope these will be more specific for the treatment of JDM. First, we've seen that from a randomized control trial that rituximab shows response in subgroups of patients that have been treatment resistant, and it works well for both muscle and skin disease. And it particularly works well in patients with JDM and those with certain myositis autoantibodies, and they may seemingly respond best to this treatment. Abbott acept and interferon blockade with JAK kinase inhibitors are showing promise in early studies, and now we have trials in progress to further evaluate these treatments in JDM patients. And we need more effective treatments for calcinosis, and we have the first trial of IV sodium thiosulfate for patients with JDM and adult dermatomyositis who have moderate to severe calcinosis. And we're hoping that these and other biologic drugs and treatments that are more targeted will offer better success in the future treatment of JDM patients. So I'd like to thank many people involved with the work presented today, including my collaborators and colleagues at the NIH, at the George Washington Myositis Clinic, and Chet Otis, Ann Reed for the rituximab trial, and many collaborative study groups, and the funders of the work as well. Thank you very much.